Automated Breast Ultrasound System, otherwise known as ABUS. So what we will be talking about. First, the background. Second, benefits and limitations of ABUS. Third, ABUS compared to other modalities. And lastly, the future of ABUS. Why did we choose ABUS? Breast cancer is the second most common cancer in Canada. It is the second leading cause of death from cancer in Canada. Current diagnostic imaging is not efficient enough to detect breast lesions. Thus, a new diagnostic technique must be introduced in order to improve early diagnosis. What is ABUS? Automated Breast Ultrasound System is a high-frequency ultrasound system that acquires 3D volume scans. The monitor displays images from all three dimensions simultaneously. The data is then used to develop 3D structural representation, which provides more detail and increased field of view. When did ABUS first come into test? ABUS was first developed in the 1950s, but due to poor image quality and high amounts of artifact, it was not approved for clinical use. However, in September 2012, FDA approved the first automated breast ultrasound for dense tissue imaging. Why was ABUS created? Breast cancers are hard to detect on patients with dense breast tissue. Almost 46% of American females have dense breast. Thus, mammography was only helpful in diagnosing 50% of the population. But with the introduction of ABUS, patients with dense breast are diagnosed at early stages, and the amount of false negatives has significantly decreased. How does this machine work? ABUS is one-of-a-kind ultrasound system that uses a 10 cm wide high-frequency transducer. The high frequency gives better spatial resolution. The raw data acquired by the transducer is displayed on the monitor in all three planes. Combined data is used to construct a 3D representation of the anatomy.
Benefits of ABUS.
Benefits of ABUS includes efficient workflow integration, providing technique standardization, and improvement in detection of breast cancer.
For efficient workflow integration, it takes an average of 2.9 minutes for a radiologist to receive images. It takes approximately 60 seconds of acquisition time, and a total examination is done in 15 minutes.
ABUS provides technique standardization. It covers entire breast and automates ultrasound scanning process, which decreases operator subjectivity and variation.
ABUS provides an improvement in the detection of breast cancer. Initially, the images are taken from the transverse plane, but ABUS provides the 3D reconstruction of those images in a coronal plane.
This increases sensitivity of cancer detection and decreases variability, which provides higher consistency of interpretation.
Now we're going to talk about the limitations of ABUS.
In order to read ABUS images, it requires a learning curve.
ABUS becomes less valuable when examining certain regions such as axillary regions, vascularity, and elasticity of breast lesions. In fact, the limitation is due to its mass size, shape, and surrounding tissues.
ABUS can find small, invasive, negative cancers that are not seen on a mammogram. Since these abnormalities require additional exams such as ultrasound or biopsy, there is an increase in callback rates. Also, we need to remember to resist any extra anxiety because most abnormalities are not considered to be cancerous.
Lastly, one of the strongest limitations of ABUS may be the cost of the examination, which is about $400 per examination. However, it is the patient's responsibility to cover the cost since it is not covered by OHIP.
ABUS and handheld ultrasound have been compared in hopes of improving patient care. But is there a clear winner for this battle? Let's first investigate if one modality is better in terms of diagnostics. There has not been definite evidence that one modality is better than the other. Patients with a palpable mass were scanned by both modalities. It turns out that both modalities performed at a similar level with insignificant differences. One specific study performed both ABUS and handheld ultrasound scans on breast cancer patients. The number of lesions in the group totaled to 80. ABUS detected 70 of 80 lesions, while handheld detected 65. But we also need to consider that there were 3 lesions detected by handheld that were not seen by ABUS. What does this mean? The modalities track different lesions and neither are perfect. There are some clear benefits of ABUS found. However, these benefits are not so much related to the accuracy of imaging, rather they're toward patient care. ABUS is more easily reproduced. Also, scans are done at the same level whether it's by a trained sonographer or a mammography tech. This is from a study. Actually, there is no need for a trained operator with ABUS. Any responsible healthcare worker can obtain these images. And workflow is improved because the timing of scans is consistent. ABUS also allows anatomy to be viewed in the coronal plane more easily when compared to handheld. Plus, the field of view is larger. Overall, it can be noted that there are not yet enough studies to conclude that one modality is better than the other for diagnostics. What has been found so far is that they have similar abilities, and instead of eliminating one over the other, we should be pairing them for improved imaging. For our workflow, however, there are definite benefits for ABUS since anyone can perform it, and scheduling patients is much more accurate.
Okay, so now we're going to be looking at how ABUS works with mammography. Mammography is a modality that uses low-energy X-rays to identify breast cancers. The benefit is that it has high spatial resolution, however it has a major limitation, which is that it's not as effective when a patient has higher breast density, so this population really needs another modality that works better for them. So mammography has lower sensitivity for patients with dense breasts, which is an area that ABUS can help improve. A retrospective review of women with increased breast density found that when ABUS was combined with mammography, it reduced advanced stage cancer by 10.8% for invasive cancers. And this is likely due to increased breast cancer detection. Another study involving women with dense breasts found that the addition of ABUS to mammography resulted in the screening of an additional 2.4 breast cancer cases per 1,000 women. Similar findings of ABUS improving breast cancer detection was found in several studies. So overall, there were significant benefits when adding ABUS, but mainly for women with dense breasts. Because the additional benefits for ABUS are mainly seen in patients with dense breasts, it's important to know which patients are categorized as dense breasts. Higher breast density means higher amounts of fibrous and glandular tissue and decreased fat tissue. Another reason breast density is really important is because higher breast density also correlates to higher breast cancer risk. Due to this, there are systems being developed which automatically detect breast cancer density. One system uses texture features of mammograms to determine percentage mammographic density, which is a measure of breast density. These systems will help improve healthcare efficiency and patient experience by preventing unnecessary ABUS procedures. Ultrasound-based modalities like ABUS do have important limitations when compared to mammography. This includes low spatial resolution and poor ability to detect ductal carcinoma in situ, which is a cancer that begins in breast ducts. As such, a combination of ABUS with mammography would be more beneficial than either modality alone. Because ABUS and mammography are better together than either alone, there are systems being developed which do both at the same time. One of these is called the ACESCO system, and it showed great potential in a clinical trial. It was able to detect a benign cyst in one patient and a malignant lesion in another patient. But even with these results, the images still have room for improvement.
Let's now talk about ABUS and computer-aided diagnosis together. Computer-aided diagnosis. AI has been a great innovation that has made the lives in the 21st century much easier and efficient. Computer-aided diagnosis is a topic that has been widely researched and tested upon. In the near future, ABUS and computer-aided diagnosis could be seen working together to help with pre-diagnosis for the radiologist. How does computer-aided diagnosis improve patient care? Multiple studies have shown that computer-aided diagnosis would help with specificity and sensitivity in terms of diagnosis and reporting. For example, time efficiency, the time it takes for a radiologist to report on every case. A study done in a research article showed that the reporting time for radiologists not using the computer system was 3 minutes and 33 seconds, and for the radiologists using the computer system, the reading times were 2 minutes and 23 seconds, a total reduction of 1 minute and 9 seconds per case. Below is the graphical representation from the study, which shows the difference in the reading time with and without computer-aided diagnosis.
Lastly, we'll be discussing the potential future of ABUS. In order to understand where ABUS will go in the near future, we'll need to discuss the cost to both the healthcare system and patients, and then the potential for integration of ABUS into our current system, and then lastly, we'll need to discuss how ABUS affects the healthcare system, patient care, and patient outcomes. The cost of an ABUS system is approximately $250,000 to $300,000, whereas 3D mammography systems cost in the range of around $400,000. ABUS is more of a supplement to mammography rather than a replacement, so the cost of the ABUS system is still a significant hindrance to its implementation. A bilateral ABUS scan costs the patient about $400, and it's not currently covered under OHIP in Ontario, and it's the same case for most of Canada. So this is also a significant hindrance to the implementation of ABUS. In order for ABUS to be a successful technology, it will need to fit into our current system. ABUS is based on ultrasound, which is already heavily integrated into the current healthcare system. As a result, ABUS uses the same DICOM format that is used in PACS systems throughout Canada. This allows for efficient integration without significant complications. When looking at how ABUS affects the healthcare system and patients within it, we see that ABUS is more efficient than typical ultrasound because the procedure takes about half the time. This helps improve the efficiency of the healthcare system and the patient experience. Patient experience is also further improved because the procedure is more comfortable than typical ultrasound due to it requiring less physical compression. In terms of quality of images, the detection of breast cancers is greatly improved for patients with dense breasts. However, mammography is still the gold standard for non-dense breasts. In conclusion, ABUS is an important modality that significantly improves healthcare for patients with dense breasts. However, the cost of ABUS are currently a limiting factor. Going forward, it's likely that the healthcare system will implement technologies and protocols to determine when ABUS is really needed for a patient in order to improve the quality of healthcare for these patients, while also improving workflow and efficiency. And that brings us to the end of our presentation. Thank you for your time.